Good evening, everyone. Thank you so much for joining us. For everyone joining us from far, close, we're having one of our best events yet with a few hundred registrants. So thank you so much for continuing to support the great cause that David and team have started here at TLMS. I have the distinct pleasure of actually kicking off one of the more fascinating talks I think I've ever seen over at the TLMS. Of course, this is introducing Dr. Ben Fine, who has been doing quite a lot of interesting research into the data and analytics of COVID. And in this time of uncertainty, in this time of a lot of non-truths, fake news, etc., data analytics and getting to the truth of the matter of what COVID is and how we can get it is an interesting use case for predictability, which is, of course, the foundation for anything in machine learning. So it's going to be an exciting talk. I'm looking forward to hearing Ben. He's an affiliate scientist and the physician lead for the Operational Analytics Lab at the Institute for Better Health, Trillium Health Partners. That's where he's presently working. But he's also practiced clinically there as well as a physician lead for quality and information. He's also affiliated with the Center of Healthcare Engineering at UAT, led the Tech and Apps Work Group of the Canadian Association of Radiologists. He's done research in informatics interested, including machine learning, lean thinking, improvement science, and a nudge to reduce costs, weights, and errors. Certainly a topic passionate to my heart in digital reconstruction and excellence. Again, an investigator in the health stream of the Creative Destructive Labs at Rotman, holds a Master of Science from MIT and an MD from the University of Toronto. And as mentioned, has his residency in diagnostic radiologist at the Fellowship of Muscular Skeletal Radiology. So that's quite a mouthful. It certainly is indicative of all he has to bring to the table. Dr. Fine, if you're there, I'll ask you to please open up your camera, your microphone, and we'd love to take any questions you have from the audience into the Q&A or FAQ list. We'll collect those and at our best try to answer them at the end. Dr. Fine, over to you. Thank you so much.
Okay, I guess I'm unexpectedly giving Dr. Fine's portion of the slides as well.
That's awesome. Liam, please introduce yourself if you don't.
Start out. Yeah, I will. Someone from the team could shoot him a message. Maybe we'll be able to figure it out there. Are my slides coming through properly?
We can see them. I'm going to try to get rid of my video, but you can see you and your slides, and we will look to try and find Dr. Fine. So sit tight. Thank you so much, Liam.
Perfect. So hi, everybody. My name is Liam McCoy. I'm an MD/Master's/Computing for Medicine student at the University of Toronto. And about a month ago, or a month and a half ago now, it's crazy how time flies in this quarantine, I started helping Dr. Fine out with the COVID Open Data Analytics Collaborative, or HowsMyFlattening.ca, a website that is dedicated to trying to cover all aspects of this COVID-19 pandemic and to get the data from its various siloed sources into where it needs to be for both the public and decision makers to effectively double click. Oh, sorry, that's advice for people other than me. Double click on those slides to make them larger. So the spark really came on March 15th when we were starting to see articles out of places like Italy where physicians are starting to have to make wartime triage. The health system is becoming overwhelmed by the amount of cases that are coming in. And really the question of what does this mean for Ontario? This seems to be an inevitability. It's coming down the pipeline. And when it comes, what is this going to mean? There's a lot of data out there, but it hadn't really been analyzed in an Ontario-specific context. So the data we're given is not really given in a machine-readable format. You'll either get sporadic government updates or non-machine readable PDFs that we then have to transform back into data that's suitable for the sake of analytics. So yeah, that's really what a lot of the work started out as, was going to all these different government releases and entering the information about the number of cases, about the number of beds, and starting to do that preliminary modeling in order to figure out what does our testing capacity look like? What does our healthcare capacity look like? How successful are we at flattening this curve? And ideally, we want to have an easy version of something similar to that Financial Times diagram on the left of this slide, where we know what's happening and we know it in a sort of easy to understand and easy to comprehend way. So that's where sort of the How's My Flattening group stepped in. We started out with trying to figure out, what curve are we going to follow? Let's compare Ontario to South Korea, who had a very excellent early response, Singapore, who had a very fast early response as well, or Italy, who sort of skyrocketed off and, as we noticed, overwhelmed their healthcare capacity. On the front end, we have the HowsMyFlattening site. That's HowsMyFlattening.ca, and you can come take a look at our beautiful new dashboard during this website, or during this talk if you want. But the back end is really our team. We have 123 active members in our Slack. We have people from all faculties. We have a core team that's consistent of a couple medical students, a couple of PhD epidemiologists, researchers, a few epidemiology/public health students, a few health informatics students, and the computer science side of teams. So this is people with a strict computer science background, or people with a more computer engineering background, the people who do all the really hard computer stuff that I personally don't fully know how to do. We have a really nice mix of skills in our team, as you can see here, and that's really been the secret. It's been incredible for me to work as part of this team with this ad hoc collaboration that has brought together people forming teams and forming sub-teams and forming sub-projects, etc., in a way that is very much a sort of, we use the wartime collaboration metaphor of just getting things done, identifying things, taking things and running with it, and it's been a really great culture we've been able to build. And of course, we can't forget our various supporters like Trillium Health Partners, the Vector Institute, Click Health, Tag Labs, and HIMSS Ontario, as well as the Dalhousie School of Public Health and U of T. Oh, perfect. Look at that.
No, you're doing amazing. Don't let me interrupt. Am I supposed to keep going?
Sure, I'll pass over to Dr. Fine for our message.
Keep going. I don't even know what slide we're on.
Can you see I'm Carol Boy?
Oh, there you go.
Okay, I guess I'm going to talk. Our mission is to deliver trusted real-time data in one place, to initiate the analytics collaborations from one place, and help to monitor and inform these Ontario curve flattening activities that we're working towards. One of the major features of our website is the data set. So we are collecting data sets from all these disparate sources, and we are putting them into a single spot. So we have case data, we have mortality data, we have this in a machine readable and machine accessible way. We have a bunch of database stuff that I'm not enough of a computer scientist to understand, but some great work has been done on the back end for this part. And our data sources are often really creative. So the epidemiologic data made by J.P. Susi and Isha Berry, two students of Dalhousie School of Public Health, and with a bunch of other collaborators, has essentially consisted of going in, finding these PDFs, scraping the information necessary from these PDFs, and getting it into that machine-readable format to lead to all of our beautiful analytics that we were able to have on the website. And sometimes the data set is not just in a PDF somewhere, it actually doesn't exist. So this was the part I had signed up to talk about on this talk, so hopefully I come into my wheelhouse here.
You know, I'll introduce you for this part just to like do the context around it, so it sounds even more amazing when you hop in. You know, so,
sure,
so you have all this data. Oh, I'm going to turn this off so there's not an echo. Excuse me. Hope you can all hear me okay. But, you know, the real question, next slide, is, you know, if you think what's going on in the world right now, and that is a series of natural experiments where we look at all these different curves. You can say, take China versus Austria versus the US versus South Korea. You say it's the same virus. It's landed by travel other than China. It has infected reasonably dense populations, which are all, you know, certainly in urban centers. So you would expect spread to be somewhat similar, but what's actually different about all these places? And one of the big things that's different is what has each jurisdiction done to try and prevent spread of disease. And the really only tool we have in the absence of immunity to prevent spread of COVID-19 is distancing, separating humans from one another so that they cannot spread the virus. And so how has that been accomplished in various different places? You can qualitatively, we know, looking at places like like the US, if I may, where there was very little action, certainly not quickly, and community spread was allowed to occur, and numbers quickly increased. Then you have places like South Korea, where you read about what they were doing as soon as they realized they had a problem at the end of January. They basically called massive testing and tracing strategy to be implemented widespread, testing 10,000 people a day, and used that along with various forms of distancing to really. And so we know there's these examples of natural experiments out there happening all over the world, and the same thing in Canada. And so the question is, why do some curves look different than others? We know there's stories coming out of it, but how do we start to quantify it? And how do we start to do analysis of it? And how do we start to make it relevant for Canada and Ontario? Because ultimately the decisions that drive how well the distancing is will impact curve flattening will depend on federal, provincial/territorial, and even local interventions. And so that is the question, is why do some of these curves look different than others? And then you go to ask, well, how do we know what everybody did? And I'll hand it over to Liam.
And exactly, I think that's a great summary of it. You know, a lot of the existing data sources that are out there only look at the national level, but a lot of, based on Canada's constitutional framework and just based on the way the country is, a lot of what really matters is being done at the provincial and local level. So I looked for this data set. I assumed I'd be able to find this data set. This data set did not exist, therefore we made this data set. So we rapidly found a team. I crowdsourced a bunch of my classmates at U of T Medicine, all of whom suddenly had a lot of time on their hands after being kicked out of the hospital. And we assigned people to every one of the top 20 cities in Canada, as well as all the provinces and the territories. And we got people to look at government sources, social media, news agencies. We identified and we extracted information about what kind of intervention, who's it targeting, where is it targeting, what's the time look like, and we connected it to some other broader initiatives that are happening sort of throughout the world. So we ended up with a big spreadsheet, nice machine readable format. We had free text summaries, we have the text of the announcements, we have all this juicy stuff in order to, you know, make sure we didn't just go from PDF to PDF, but do it in a way where we can actually do some robust analytics. And brief summary of the type of analysis we can do with this data set by itself, but also in linkage with other data sets. You can do things like looking at when interventions happen. So there were little bits and pieces here and there, but clearly it was that middle of March, the week of around the 11th to the 18th, when the WHO pandemic declaration came in. You know, the NBA shut down, and North America very much quickly woke up to this reality of COVID-19. Our data set with the spatial components also allows us to compare the stringency of the different provinces, who responded first, who responded most heavily. BC had the first cases and deaths in Canada, and BC was the most stringent from its initial response. And then finally, I think this is the most exciting possibility that I'm looking forward to playing around with after doing all the work of building the base data set, is linking this with other sources of data to see both what caused the interventions and what the interventions impacts were. So here we have a graph that looks at the first case announcements in each of the different provinces in Canada, compares this to the first death announcements in those provinces, as well as when state of emergency was declared and when that school closure was declared. And again, you can see that sort of that week of March 12th to the 23rd or so was really where things tend to cluster around here. We have some exciting next steps. So the goal is to keep updating this bi-weekly throughout the course of the entire pandemic, linking it to other data sets. There's things like case data sets, economic data sets. There's really a lot of fun we can have here. And then finally, feeding into international collaboration. So there's groups at Oxford, groups at Johns Hopkins, and we want to make sure that this robust Canadian data is included in helping to sort of define this story, and in particular, sort of pressure some of our counterparts to consider the subnational level as well, because in countries like Canada and the United States, it's incredibly important to know what the cities, what the states, and what the provinces and territories are doing.
Awesome. Liam, maybe I'll get you to keep clicking along as we continue the story. And so, you know, the number one thing we want to do is put the data in one place, make it easy for people, anyone who wants to wrangle it, to have a single credible source to access it. The second thing we want to do is now, data analytics for healthcare is hard, and it's always been hard. It's hard because you need to combine both knowledge in the business problems and in the understanding of the data with the methodologies and talents of data scientists, engineers, computer scientists of the world. And so we've tried to create an environment where that happens in two ways. So the first is on Slack, where clinicians and epidemiologists and data scientists can kind of exchange ideas about how to make sense of a certain problem and potentially how to address it. And the second is through Kaggle, where we've tried to leverage the fact that the data is now all in one place, and open up to challenges with specific questions that we know will help guide those with the right type of talents, again, clinical, epidemiologic, plus engineering, data science, to help make sense of all this data. And so we started running challenges to see what insights would come. And there's some amazing things that have come up. I'm just highlighting two here, which are similar themed around, okay, well, we know ultimately for the spread of the disease, the R naught, or really the RT in this case, which is a real-time estimate of the R value, dictates how much spread is occurring based on the number of tests that are positive test cases trend per day. And what we're aiming for is under 1. And both Alf and Jonathan from two different places arrived at similar analyses to help visualize how we're actually doing. So the third thing we're trying to do, and we welcome participation. Even there was an engineering class from Waterloo who decided to take some data, combine it with other sources, and derive some interesting insights. The last thing we're trying to do is put this all in one place. I'll give a high-level overview to some of the stories that we're telling on our website, but won't go into too much detail, and encourage people to add HowsMyFlattening.ca to the thing they look at on a daily basis to help monitor the response to COVID. We started with that graph of healthcare capacity versus the number of tests, because that was the big concern. We've kind of peaked. Now we actually have two different curves happening. This graph, which is now our front page, shows that, as we know, community spread is somewhat leveling off, although it's happening a little bit more than we would like it to. But really the big news story is that these congregate settings, the disease is running wild. And that's what these green bars are showing you. And that's what we'll continue to track on a daily basis. And any data analyst looking at this says, hey, this data is kind of weird. And that's a theme that will keep emerging and we'll talk to at the end. We've done largely descriptive analyses so far in various different categories around capacity planning. So if you wanted to know in your region, which is the unit of decision making that matters, because you need to know how many patients in your jurisdiction might need a critical care bed, for example, you can monitor that in real time here, and you can tell that certain regions capacities, although thankfully today, overall, there's plenty of capacity. The second is around testing, and monitoring this data dynamically in real time introduced some very interesting observations that eventually funneled to the command table and how decision making has happened in Ontario, or where it happens. And first we saw that there was this big backlog of pending tests, and you can see that here with the first blue bump. And then second, we started to see this crazy trend of crazy high positive test rate, looking at the right axis. And that's insane, because that means that we're not testing anybody. The actual prevalence of the disease is much lower. And a different analysis, which we didn't show here, demonstrates there's probably 10x the number of cases that are actually in circulation in the province than we're actually measuring. You can drill down by region, as we kind of talked to before. We've tried to pull all the mobility data from various sources. Google and Apple are providing theirs as well, overlying some of our intervention data to show you how social distancing, this is one proxy of measuring. People aren't looking up where to go anymore because there's nowhere to go. you should be staying at home for now. Also, an interesting lens that we're bringing in is kind of the socioeconomic story. The takeaway from this graph, don't have a ton of time to walk through it, is basically showing for different types of cases where what socioeconomic status as measured by the Ontario Marginalization Index, which basically tells you how much wealth or consuming power an individual has. You know, if you look at travel-related deaths, travel-related cases, which you can imagine is just how the epidemic started, versus community spread, you can see that these dark blue bars, much higher proportion of people are obtaining the disease in lower SES portions of the population than in the original travel cases, which you can imagine there's a lot of people in this province who don't have the luxury of staying home and staying away from people, and whose jobs are either required or their living conditions don't allow them to be separate. We also have the kind of FT.com style plots relevant for Ontario compared to other provinces and other jurisdictions. We've also looked at mortality. So everyone's like, how many people are dying of COVID relative to other conditions? Well, the answer is kind of simple, and it's, you know, depending on the day, it is either the second or third leading cause of death in the province on a per day basis. We tried to summarize a lot of this in a dashboard that just went live, so we welcome feedback as we iterate on it. And I think really what lies ahead, and this is not a 15-minute conversation because we've been talking for way too long, so I'll stop soon, is when we get to put all these data sets together. And that's really what we're opening up to folks like yourselves who are watching and participating today in the data science community in Ontario, to say, how do we make sense of all this data? Because yes, there are some very smart, talented people who've been tasked with figuring out certain things, but we know COVID's moving fast and we need to move faster. So the more smart people looking at this data from different perspectives and coming up with insights, the better. Here's an example of one. JP Susi and Isha Berry and others who are all awesome as well, put out this preprint about looking at how does the mobility index, there they pulled from kind of transit logs or a transit app versus the actual growth rate of cases 2 weeks later, and showed that you know, if you're moving less, there's less growth. It's not earth-shattering per se, but just proves the concept here dynamically for people. Similar idea, if you can put MPI stringency with testing, if you can show or the number of positive cases, those that have been more stringent, like South Korea or Hong Kong, compared to places like Sweden, you can see for yourself what that means. Certainly there are challenges here, and I'm going to stop talking soon, but I see that the chat is active and happy to answer there, or as we move beyond, is that Ontario itself, to be frank, doesn't have this data in order. We're trying to solve for it as much as possible, but you get feedback like this saying, once I switch from Toronto to Ontario, I get different numbers. Well, it's like, they're actually not concordant. The numbers Toronto and Ontario are using are different. Here's another crazy graph on the my right of the screen, or radiologic left, is that the ministry itself is showing its two sources of data because it's not sure what's the truth. It's showing one, what the ministry gets directly from long-term care facilities, and then what Public Health of Ontario gets. And they're, in this case, I applaud them for being transparent and saying like, hey, this is as much as we know, so we're going to share it with you. So I guess to summarize, some of this is disorganized because this is like 45 days old, but it's amazing what we've been able to do, bringing an immensely talented pool of talent together in Ontario, people who care about making sense of the data processing of the data for COVID. And I hope that we're really showing the value of open data and open analytics and that mindset to really move quickly to generate health insights, which again, Ontario is not known for. and then really trying to put them in one place to help inform decision makers and influencers and people like yourselves to help have a better sense of, what on earth is going on here. So I will stop talking. I think we'll try to address any chats. Welcome anyone joining us. You can send us a note, hop in. There's lots of things you can do to help. And really want to thank again some of our supporters, which has much of this work so far through their COVID 2019 kind of rapid research grants. Dalai Lama School of Public Health, Click Health, Red Hat in kind of building that open source community, Google for some cloud credits, and Ontario HIMSS chapter for really believing in us and helping connect us to folks, and obviously all these amazing people around the table who have made this happen. So I will stop talking. I said that once before, and I'll actually start doing it now and see if we can answer anybody's question.
That was great, Ben and Liam. Thank you so much for stepping in, both exceptional. Please, anyone who you do have any Q&A, if you can see anyone in the Q&A, drop in your questions. But I did collect one question, and it's a great segue, Ben, to your point about the thanks. You touched upon in your conversation about sharing of data, the things that are happening for you to kind of cleanse the data, move forward. In 2 or 3 statements, what do you think are the key things that you need to get help with to sort of really get that data cleansed and movement? You touched upon it, but I just was wondering if you could back it up in the corner.
That's a big and messy question, and that is a question that
Looks like we briefly lost Dr. Fine.
Yeah.
I guess ad hoc giving my thoughts on what you need for the data. I think recognizing the importance of the machine readable format and recognizing that we have this incredible latent capacity in Canada for data science. We have incredible people who are able to work with this data to help drive insights. And it doesn't just have to be the people who are traditionally within the public health space. We have a lot of citizen science going on around here. We have people building their own dashboards, et cetera. And I think the fact that the data is already in a machine readable format and it's being analyzed internally, and then it's put in releases in PDFs, which are themselves incredibly helpful, incredibly useful. But I think recognizing and trying to formalize those pipelines between the machine side and the machine side among the public, I think can hopefully be useful to help us keep driving insights and help keep framing things properly.
Great.
Sorry about that.
No worries.
Liam did a great job. I know we're running out of time, but that is to solve. And if you know anyone who you can encourage who works in government to adopt some of these open data, sharing data approaches and show, as we are here trying to show the value of what we're doing, I think that's where we're going to start to move the needle, because these are not new problems. They're just becoming painfully obvious during COVID when we can't move fast enough.
Yeah. All right, gentlemen, thank you again so much. It was really fascinating. I look forward to connecting with you guys offline about that very topic. Thank you. Have a great evening, and please join us for any of the other events you'd like to. Have a great evening. Thank you.
Thank you, everybody.